So our first objective really was to improve access and experience with this transition work for young people, and then whether this same sort of service could be applied across the rest of the caseload for parents of all children with epilepsy, and to assess the outcomes and experience not just for users but for staff also. So we were successful in an application for a sequin over a 12-month period. This was helpful because it gave us admin support, but it didn't give us any additional funding or staffing for what is a really busy service. So there were lots of constraints on time to deliver the project. However, we started with a parenting young people evening, which gave us valuable feedback and opinion about the possibility of this service, and also gave us some volunteers. The IT options were explored by our trust IT provider and somebody from the business team. They looked at the control of the systems, industry standards, security, and we also involved the information and clinical governance team. They were helpful in looking at consents, and they also sent us information for information sharing, or GDPR, as we all know now. And they sent us a document that was more than 3 pages long. So we cut it down, and then we cut it down again and simplified it. But the reality was, I doubted whether parents were going to read it, let alone the young people. And then our head of services had a really good idea about developing a YouTube video, which explained all of the information needed, including how the virtual clinics operated. And we were very fortunate that we had young people come forward to take part in this video with us. No arm twisting involved, of course, and that's now available in the public domain, and it's easily found on a search. As far as the process was concerned, we decided to maintain our usual use of the tool, the healthcare schools tool on the ePen website, but we also started to incorporate the Ready, Steady, Go program that Dr. Nagra from Southampton had developed. Apart from myself, we have a very experienced Band 4 associate practitioner who also offered the virtual clinics. Inclusion was youngsters 13 to 14, 18 to 19, without learning difficulty, and also they had to have the IT and internet access required. So the software of choice was something called Cisco Jabber, supported by our local IT provider. We set up a secure nhs.net account that was used just for this service. Test emails sent. When they were returned, they had all the information, and we had insisted on explicit consent, and an appointment was booked and a date agreed with the young person. We allowed 5 minutes either side of that appointment time for them to contact us. And this is just a couple of clips from the YouTube video, but this is really demonstrates quite clearly how it works. So at the time of the sequin, we had 61 on the caseload. After exclusion, we had 30. We couldn't contact one of them. By the end of the sequin, we'd completed 19, at least, virtual clinics. 5 declined, preferring face-to-face, or declined transition support anyway. 4 had no IT available, or they felt they were ready for transfer and didn't really need any more support. As far as the patient and parent feedback was concerned, we only, unfortunately, got 7 responses to our email. Having said all of that, verbally, all of them recommended it. From the patient point of view, they liked the hospital appointment. It felt like a hospital appointment because they could see me, but it felt more private, less waiting time, and that was quite a theme throughout the feedback we received, actually. One liked being at home, didn't have to travel, didn't have to wait. and no connectivity issues. From the parent point of view, convenience, no travel again, getting time off work, that was another thing that came up more than once. From the parent point of view, for two particular parents, they felt that it was particularly useful. One had ADHD and autism, and one had confidence issues, and both felt they had a positive experience from the virtual clinic. From the staff point of view, we had a small office where we delivered the virtual clinics from, and so obviously we didn't need a clinic room. That allowed for fairly prompt rebooking for any concerns. I felt particularly that the virtual clinics were more young person focused. When they'd come to a face-to-face clinic, it was sometimes difficult to separate the parent from the young person for different reasons. It certainly, as a community nurse, saved time on travel, and actually there was a cost saving to that. It allowed flexibility, not just for other virtual clinics, but for other appointments. They didn't all have the IT required, and there was some variation in the connectivity. We also recognised it can't always replace a face-to-face contact. The other problem we had was that this was an unfamiliar type of appointment, and therefore there was this tendency to begin with for them to forget. So we resolved this by sending them a proper appointment letter by email as a reminder. We felt it was a new skill to develop. It's a different way of working, but even I adapted quite well with my challenges. What happened, certainly during the latter weeks of the sequin, is that it started to change from very much a transition information sharing service to one of a more complex clinical need. So at that point, of course, it was myself delivering that type of service, not the Band 4. And this meant that we almost seamlessly went from just it being a transition support mechanism to one of clinical support. So certainly since January, we've had 14 parents and young people or children who have been offered at least 1 to 5 virtual clinic appointments. Initially, there were a couple of youngsters who had significant mental health problems with suicidal ideation. It allowed me on one occasion to contact the young person via the virtual clinic in a very timely fashion within a couple of hours of finding out there was a problem with an urgent referral to CAMH. Another one who had particular problems with behaviour was starting to physically attack parents, so both the parent and young person needed support. There was another youngster who had decided he was too frightened to go on the train to college and therefore wasn't attending education. As far as the complex epilepsies themselves were concerned, it allowed me to talk to parents, get a better feel for how they felt their seizure control, their child's seizure control was doing. They could show me what the children's seizures looked like, much as you would in a face-to-face clinic. As far as kind of some of the more difficult medication changes were concerned, it also gave me a better assessment as to whether I felt the parents were understanding what I was saying. And particularly in a town like Luton, where English is often not the first language, I think that's really important. There are a couple of particularly hard-to-reach families. One was a traveller family, and they were travelling between Luton and another area, were not attending clinic. They were engaging with this type of service very well, and a parent who was finding it difficult to take time off work because she had 3 children all needing appointments. So that kind of service really suited the parents. And the other thing I used it for was information for referrals rather than having to do home visits. So we decided we need to do a new YouTube video, and we've got 2 parents involved in that, and that will be available at the end of this month. So from the perspective of parents, what was the impression? Good, very good. How accessible were they? They all found it easy, very easy. There were 7 responses. 1 preferred to use the link on the email each time. 1 had wanted instructions each time. 4 said that being face-to-face virtually was positive, saved time. 2 cited convenience and being at home as positive. Certainly busy working life for 3 of them. And 6 out of 7 cited not coming to hospital as a positive. And I'm sure when people are trying to park at any hospital these days, they'd agree with that. Would you recommend? 7 out of 7 said yes. What could be improved? Good as they were. 1 wanted the link each time, which is not difficult. From my point of view, more issues with downloading the app, but we managed those in-house. It wasn't done by me, that support, but by certainly in-house. There were 3 occasions when we lost the connection, probably because of problems at the user end. It continues to save time on travel and cost and booking clinics. Access and engagement has improved. There is a lot of flexibility. But I was also recognise that it's still a developing skill, knowing when you would offer a virtual clinic, when is a telephone call enough, or when is it really face-to-face contact that's needed. So I'm not going to go into all of those evidence articles because we haven't got time. I don't think Richard would allow me the right time. But just to say that we've done 3 searches so far, 1 at the beginning of the sequence, 1 at the beginning of this year, and we've done 1 last month. And I can't find anything to date on use of virtual clinics in epilepsy. Okay. So the conclusion offers viable alternative, flexibility, reflects the needs of some young people and parents, not all. It can reduce time out of education, time off work, improved efficiency, can reduce waiting time, and I would completely accept that a more robust evaluation and research would be useful for this. What next? Could it be applied to your service? I know Sharon from Peterborough was thinking about doing virtual clinics in Arran in West Sussex. If anybody else is doing it, I'd be really keen to talk to you.